My name is Yves Blay. I'm a medical oncologist. I'm working currently in the Comprehensive Cancer of Lyon Centre-Léon-Bérard. I've been working on rare cancers during all my professional life on a variety of different rare cancers, recently mostly on sarcoma. I am the president of the French Sarcoma Group and I am the network director of EURACAN, the European Reference Network on Rare Adult Solid Cancers. The definition of rare cancer is a definition which is based on incidence. A rare cancer is a cancer whose incidence is inferior to 6 per 100,000 inhabitants per year. So that's the definition. There are major challenges for rare cancer in general, and there is a large number of rare cancers. Altogether, rare adult solid cancers represent about 22% of patients with cancers, but represent about 30% of the death related to cancer, which implies that actually the treatment and management in general of rare cancers is more complicated because of diagnosis, because of therapeutics, because of research, which is more challenging in rare cancers than in common tumors. There are many things which differentiate rare cancers and frequent cancers in terms of diagnosis and type of treatment. Maybe the first one is the difficulty in diagnosis which is observed in the majority of rare cancers, simply because the doctors and pathologists are not seeing that many rare cancer numbers throughout their professional careers. So not infrequently, rare cancers are misdiagnosed and require a central pathology review to have a proper diagnosis. And this is happening in the tumor which I treat most frequently, which are sarcoma. This is happening in a range of 30% of the cases where pathology review changes the diagnosis, sometimes major changes such as benign to malignant. Now for treatment, also there are differences. The main difference is that the standard of care are less well defined in rare cancers as compared to common cancers, simply because there has been less clinical research on rare cancers because of their numbers, because of their diversity, because of the low incidence, which has not favored the emergence of a dedicated clinical research program. How are patients identified with a rare cancer or suspected of a rare cancer oriented towards the reference centers such as those present in EURACAN? That's a complex topic. Actually, we know that patients with rare cancers have delays in diagnosis and sometimes inaccurate diagnosis. So this pathway of the patient must be organized with a connection between the reference center and the primary care center or the general practitioner. This requires communication, this requires extensive exchanges in a networking context with your regional connections as a doctor in primary care centers, secondary care centers and general practitioners. This is the best way for the patient to solve the question of delays in diagnosis and delays in treatment. The connection, information, communication with the healthcare professionals. What are the breaks or the difficulties or the bottlenecks for clinical research in rare cancers? There are multiple. The first one is the rarity of the tumor, which of course makes complicated to have large series of patients. The inaccuracies of diagnosis, the limited resources for clinical research, both from the academic side and from pharmaceutical company partners, the difficulty to get funding in general, and also the difficulty of methodology related to the fact that they are rare, which makes sometimes randomized clinical trial not feasible or not feasible with enough power, and rare cancers should not be discriminated against simply because they are rare. So in view also of the fact that more cancer are going to become rare cancers in the future, we need to solve that methodologically, and we are in a good shape to do that with EURACAN. But that's going to be an extensive work for the next decades. How do we work with other professionals to obtain a rapid and accurate diagnosis of rare cancer and to orient best the treatment? That's again a big challenge in general throughout Europe for the management of rare cancer patients. I think the key is networking. Of course, EURACAN is a network of reference centers, but each component of this network, each healthcare provider must itself be connected to others through its own network. So this can be a national network, sometimes a regional network, but this connection with healthcare professionals in the close vicinity, in the surroundings of the healthcare providers is crucial, so that you can share the information, facilitate the transfer of the patient from one site to another, establish connection, and in general facilitate all elements of patient journey, from diagnosis to treatment. So we need to be connected to the general practitioners, to the surgeon, to the radiologist, to the pathologist, in order for them to know where they can refer the patient, or at least ask for information or second opinion nearby. That's a networking activity which is crucial to the activities of all ERNs, I guess. How do we collaborate between primary care centers and reference centers such as those of EURACAN? That's a big challenge. Actually, it's always a question of connection in a networking and also communication. How do we communicate our existence as reference center to all primary care centers and ideally to all general practitioners, so that patient journey is facilitated with that? I think it's a question which can be addressed in a very different way across countries, because the healthcare system are not necessarily alike in the different European countries. But the key thing behind that is communication. We need to be connected to the primary care centers, and we need to make ourselves known. Why are we doing this? This is because it has been shown to improve patient outcome and survival, and we can do better if we work together. That's the main message. I think that's a general message which is very well heard. There is another topic around this question, which is how do reference centers collaborate? And that's part of the activities of EURACAN on connecting the different reference centers between themselves in order to facilitate patient journey when therapeutic strategies are available only in a small number of sites. But that is something which is quite well functioning already within such a network. What are the main challenges of the patients in terms of reaching the best treatment? Well, there are multiple. First, I would say recognition, identification that there is a rare cancers behind these symptoms. This takes time, sometimes too much time, sometimes longer than what is happening for common tumors. That's the first challenge. The second challenge is to get a proper diagnosis, and a proper diagnosis without affecting the subsequent treatment of the patient. A biopsy must be conducted, for instance, in an expert center because this is one way to shorten the diagnosis, but also one way to avoid to do an inappropriate biopsy which may impair the subsequent treatment. Then the third challenge is to get to the right center to propose the optimal treatment. And this is again one of the tasks of the EURACAN centers, to be able to organize, again in a networking organization, to organize the patient journey appropriately, so that the patient can receive standard treatment in the closest place where they live, but most often it must be conducted in one of the reference centers for rare cancers. So three major challenges: shorten time to diagnosis, optimize the diagnosis, and optimize the treatment as close as possible to the patient home, but also to the highest level of standard as possible, closest to his home. What is the role of clinical research in rare cancers? Well, clinical research is at the beginning of everything. Rigorously, you need to evaluate your strategy using clinical research. And one of the big problems of rare cancer is that clinical research was not that much developed. Things have been changing over the years, and in the last 10 years there have been an incentive for academic researchers, for researchers from the pharmaceutical industry to develop more strategies, more treatment for rare cancers. So this is changing, but we have many rare cancers, and actually the number of rare cancers is increasing as molecular characterization enables and facilitates an accurate molecular diagnosis of new entities which are now being identified more routinely than before. Though we have a next challenge. It's not necessarily only to do clinical research, which proves that you improve patient outcome, but you need also to make the treatment available for all patients. And that's the role of the interaction with health technology assessment bodies in the European nations, in EURACAN territory in general. And I think one thing which should be extremely clear is that rare cancer cannot be treated as common cancers in terms of approval. Simply because we cannot do randomized clinical trials with 1,000 patients per arm to show improvement as compared to the previous strategy. This is simply not feasible when you have a disease which is affecting 30 people per year in a country like France. So we need to have other methodologies, other strategies, otherwise the patient with rare cancer will not progress in having standard treatment. That's a major challenge for immediate future. To which extent COVID pandemic has affected the treatment of patients with cancers in general is a big question. So the numbers which have been shown by large epidemiological studies are quite frightening. It seems that delays in diagnosis, delays in treatment, sometimes no treatment, was observed in an increasing proportion of patients during the years 2020 and 2021. How are patients with rare cancer affected with that? That's a different question. Well, when we looked at the numbers in countries with registries, it seems that year 2020 for most countries we observed a decrease in the number of diagnoses, suggesting that probably some patients did not achieve the full patient journey. Now, if we look now at the situation in the country where we work, the organization in reference centers seems to have kind of protected the patients with rare cancer from this general observation of patients with cancer. And actually what we observed is that there was, over those 4 years from 19 to 22, we observed a relatively stable number of patients diagnosed and treated in the reference centers and nationwide, which is kind of reassuring and probably tells us that a rigorous organization in reference centers is protecting probably patients from delays in diagnosis. But I think time will tell for the broader European community. Which advice could we give to the patient affected with rare cancer to get the information as quickly as possible and to be able to join a reference center? I think that's a big challenge. I think the best information that we can probably provide is available now on EURACAN website. Information on the close reference center, information on existing networking nearby to your home, information on the symptoms which should lead to a diagnosis or consultation to the general practitioners. This is available on our website. We need to do much more. Actually, one thing which is critical, and this is going to be our work for the future, is to better connect the networking activities of EURACAN to that of the healthcare system, the individual healthcare system of each nation. That's a work which should be conducted nation per nation, and we have a lot of work still to do to improve that in all countries. But I think the best piece of advice that we have is to get the information from the sources which are reliable, and the website of EURACAN is providing reliable sources. How do we improve the care of rare cancer patients requires further efforts on the organization of care, of diagnosis, but also on communication. I think communication on the existence of rare cancers, what are the specificities, what are the difficulties for diagnosis, how the patient, how the relatives, how the healthcare professional, general practitioner, radiologist, surgeon should provide necessarily a diagnostic pathway and treatment pathway is mostly a question of the dissemination of information. So communication will be the key. Improving the communication and improving the quality of networking within each nationwide healthcare system is going to be critical. So it's a mixture. It's a mixture of connecting the reference centers to the healthcare system and improving communication European-wide in order for all European patients with rare cancer to be informed of the possible solution to treat and diagnose his tumor. How do we give information on the nature of disease, natural history of disease, and information on treatment of rare cancer is a bit specific as compared to common cancer. Well, the first point is that many patients come to us having been connected already to healthcare professionals, and often the discussion led to, well, this is a rare cancer, I do not know it very well, so I cannot tell you a lot of things. So the first thing which is very important to provide to the patient and relatives is information. You have this tumor, this is the natural history of this tumor, we must treat using this and that because of this and that piece of information that we have from previous sources. This is already extremely reassuring for the patients. Having people knowledgeable on the disease which is affecting you is very important. Now there are more frequently in rare cancers than in common cancer situations where we do not know, but at least sharing with the patient and relatives that we do not know in this situation what is going to be the best solution, but to have this and that option is also something which can be discussed, and this leads basically quite often to clinical research. How do we identify new treatments for rare cancers? This is basically the question of precision medicine in oncology and improved local treatment. First, this is clinical research, and we have said already that clinical research is a bit more complicated for rare cancers than for frequent cancers because we need a lot of clinical research for the many different rare cancers, and because in general clinical research has been underdeveloped, underfunded for rare cancers in the recent decades. But that's a general phenomenon that rare cancer are underserved for clinical research, and we are changing that with the European reference networks. So it's based on clinical research, academic or industry promoted clinical research, based on convincing the partners that this is worth doing, and also adapting the methodology to the infrequent nature of rare cancers, which needs adapted methodology. And we have spoken already of the need for an adapted methodology for super rare entities. This is true for all aspects of clinical research in rare cancers. What are the obstacles for research in rare cancers? There are many. The rarity of the cancers. There are large number. We have a large number of rare cancers. The need for individual clinical trials for each individual rare cancers. The lack of funding, academic and industry-sponsored funding. The need for adapted methodology, because rare cancers are rare, we cannot do randomized clinical trial with thousands of patients. And finally, I would say that one big obstacle is the need of health technology assessment bodies to adapt to the infrequency of rare cancers, which require specific methodology and which cannot be evaluated with the standards of common cancers. How can precision medicine concept improve the management of rare cancer patients? That's a question within a question, actually, because we can probably say that precision medicine is transforming all cancers into rare cancers. It's a bit extreme to say that, but that's a large trend. Actually, we have seen that in breast cancer, in lung cancer. That's something which we observe, that the fragmentation of nosological classification leads to making a greater number of rare cancers. But the good news behind that is that when we understand the genetics, genomics, molecular biology, immunology of a specific subgroup of rare cancers, we generally have a therapeutic proposition which is adapted to this nature of the treatment. And that's going to be the future of oncology in general, targeting a rare cancer entity with a specific molecular alteration with a given treatment. That's the future of oncology in general. Connection between the EURACAN network and the healthcare systems of each country is crucial. Actually, even if each country has 1, 2, 3, 5 reference centers for rare adult solid cancers, their activity must be connected to the healthcare system in the format of a networking, regional, nationwide, depending on the size of the country, depending on the organization of the healthcare system, but the centers cannot be floating into space. They must be connected through simple routes to the primary care centers, to the general practitioners. And this requires a strategy which is adapted to the country. It cannot be a one-size-fits-all. It depends on the regional, local, national organization of the healthcare center. It depends on how things are getting reimbursed for each individual patient. So we need an adapted procedure for all countries, and this is work in progress. Training young doctors and young researchers on rare cancers is not that difficult, as strange as it seems. Why is that? Because the rare cancer community is well structured, is well understood in terms of connection between clinics and biology quite often, and of course there is here a major unmet need. So that's a place where a lot of things can be done for a young doctor. This is sometimes an open field. This is a place where you can build your career, build your research programs. So this is attractive. Now, having said that, we have the general problem in Europe that we do not have enough doctors and enough researchers for medicine in general, for cancer in particular. I think probably the advent of personalized medicine, the better understanding of rare cancer, make it quite a favorable area for the development of a career for a young doctor. And that's, again, one of the challenges of EURACAN, to attract the young in this question. Also because, as we said already, the future of oncology is going to be precision medicine, and it's going to be rare cancers defined by precision medicine of cancers. How can relatives and patients get information on rare cancers? That's a big challenge. And in general, the information is scarce on the internet or through other sources of information related to rare cancer. I think one of the big challenges of EURACAN at the beginning was to generate reliable information to inform patients, relatives, and the general practitioners, so a wide variety of different stakeholders, in order to provide what is mandatory to know if you want to best diagnose and best treat a rare cancer patient. And I must say that this was very much a task conducted by our colleagues from the patient advocacy groups, who did a tremendous job in generating information and documents which could be shared on the internet, which could be disseminated to the patient, to the relatives, and also to the doctors, in order to facilitate accurate information and its transmission to the patients and the relatives. This is a big challenge in general in cancer, and particularly for rare cancer patients. How many patients are treated and diagnosed suboptimally? That's a complex question. It's very difficult to measure because if you want to be rigorous, you need to have a registry gathering all patients. We have this experience in the country where I work, where we are supported by the National Cancer Institute of France, where we got funding to evaluate that. What I can tell you is that when we started more than 10 years ago, it was about 70% of the patients did not have an optimal diagnostic and therapeutic journey, 70%. Right now, as we speak, after almost 12 years of work in networking at a national level, it's over 60% of the patients who have an optimal journey from diagnosis to treatment, which means that we still have about 40% of the patients whose journey can be improved. And that's really a work which is complicated. So different countries, different healthcare systems have probably very different numbers, but at least this shows both the complexity and the success that we can have if we organize ourselves around this type of networking. Number of patients included in clinical trials affected with rare cancers has increased in the recent years. It's difficult to have broad numbers at a European level, but looking at in the country where I work, actually again using this registry I was mentioning, we observe that a substantial increase in the proportion of patients with rare cancer included into clinical trial has been observed in the last 10 years, ranging from an initial number which was probably close to 7 to 8%, up to a total number which is close to 14% of the patients including into clinical trials of rare cancers. So that's more than a doubling of the proportion. It may sound limited, but remember, most patients can be treated efficiently with first-line treatment, which is now well defined. So we have progresses to make, we should do better, but the treatment of patients with rare cancer in the context of clinical trials has been improving according to these numbers, and that's probably the case in the majority of EU countries participating to EURACAN. Patient advocacy groups in general have a major role, but in rare cancer their role is even more important. It's even more important because they are extremely well structured, well organized, knowledgeable, and their role in helping the medical community and research community to generate research programs, to generate clinical practice guidelines, to organize patient pathway, to generate information for the patient has been absolutely crucial for a network like EURACAN. Actually, the work of the patient advocacy group in generating the sources of information and the website on which patients can get the information and doctors as well can get the information has been central. I think patients are associated in general in the organization of patient pathways in cancer. But in rare cancers, they have an even more important role than in frequent cancers. And also, that's often one way by which the patient and relative can get reliable information beside those provided on the website which I was mentioning. So thank you very much, Patient Advocacy Group. We could not do anything without you, and you have been extremely instrumental. EURACAN in 3 years and 5 years and 10 years. Well, I think rare cancers require large numbers, require collaboration. So EURACAN and ERN in general at a European level is a must. We must work together. So there is no question that things will be developing further. What we need to do probably, and what will be EURACAN in 3 to 5 years, I hope will be a broader network, a simpler network, a network more connected to the healthcare system of each nation, and a network which is more capable to generate the important academic clinical research program that we need to generate for all our rare cancers. That's the way I see it. I'm quite optimistic. We need to work together. It's going to be a difficult path anyway, because of course medical demography and resources, but I think we need to have a EURACAN for the rare cancer patient in Europe. So altogether we will do better. That's our future, yes.